Good evening, everyone. Myself, Dr. Ashutosh Garg. So today, it's a very important topic. It's a general topic for EDIC 2. So all candidates are going for the exam of EDIC 2.
Yes, sir.
Okay. So today we will discuss something about the exam format of EDIC 2. I am not sure whether you know about it or not, but I will tell you some important aspects of the exam. So first of all, this is like the exam. If you go in a physical manner, you have to be seated along with the examiner, and he will share with you a screen, computer screen for the cases, CBA as well as CCS, computer-based assessment and case scenario. So first of all, there are three CBA stations. First is curves, second is imaging, and third is biochemistry. So in station 1 curve, there are 2 to 4 ECGs and 6 to 8 screen which are related to the ventilator screen and monitor screen. So total you can say 10 to 12 questions in this station of curves. So screens are generally focused on testing the pattern recognition and the physiology. So in ECG, you will get either anatomy and physiology of heart and cardiovascular system, like principles of ECG monitoring heart rate, rhythm, conduction, STT changes, QT interval, identify deviation from normal range and interpret those in context of clinical circumstance, identify abnormalities which require urgent intervention, differentiate real changes from artifact and respond appropriately, document investigations, undertaking results and action taking. So basically in exam, you will be asked what do you do or what is your diagnosis. But what do you do is more common question in exam rather than what is the diagnosis. So during EDIC exam, all ECGs are displayed in the speed of 25 millimeter per second. And there are four important things which usually asked in the exam in the 4 or 5 ECG questions. One related to myocardial ischemia, another related to the arrhythmias, third one is the pacing, and fourth is the non-cardiac disease like drug or any toxic drug or QT interval prolongation or hypothermia or some electrolyte disturbances like hyperkalemia. So in 4 ECG, these 4 diagnoses most commonly asked. One is myocardial ischemia, another is arrhythmias, third is pacing, and fourth is non-cardiac disease. It may be any drug, QT, or any hypothermia or electrolyte disturbances. Then monitors. In the monitor, there are 3 or 4 curves like arterial trace or CVP trace, ICP trace, and pattern of disease on these curves. In arterial line, they can ask about the overdamping or underdamping, hypovolemia. In ICP, they can ask about the normal compliance or decreased compliance, autoregulation. In CVP, they can ask about the tricuspid regurgitation or cardiac tamponade, constructive pericarditis, these types of CVP trace. In IABP, the correct timings, late deflation, early deflation, late inflation, early deflation, these types of the IABP curves they can ask in the exam. In dialysis, they can recognize some basic problem like access line kinged or filter is clotted. So TMP, transmembrane pressure, TMP may be increased. In this is shown in the dialysis curves. So these things they will ask in the curve station. So this is the typical pattern to recognize CVP curve, tamponade and tricuspid regurgitation. Okay, so you have to read out what types of CVP curves and what are the different diagnoses. Then third is the ventilator screen. So you can get 2 or maybe 3 ventilator screen questions. In this, you have to see what is the mode, pressure, flow, volume scalars, basic physiology. They can ask about the compliance, resistance, PV loops and FV loops, recognize basic patterns of respiratory pathology like stiff lung ARDS or airflow limitation in COPD asthma, and you recognize and diagnose asynchrony. This asynchrony is the most common question asked in the exam. Especially the trigger asynchronies are the favorite questions. So trigger asynchrony, inspiratory flow pattern or cycling abnormalities. They can ask you the graph showing the leaks or secretions. So you have to be prepared for these things in the curve section, curve station and the ventilator. So in the curves, there are 3 things. One is ECG, another is monitor, and third is ventilator. So around 4 questions from the ECG, around 4 to 6 questions from the monitor. So in monitor, they can ask you arterial trace, CVP trace, ICP trace, dialysis trace, or any other trace which can be seen on the monitor screen. Then 2 to 3 questions from the ventilator screen. So this is the one station in which 10 to 12 questions will be asked related to ECG, ventilator and monitor screen, and total time is 15 minutes. So maybe around 1 minute for one question, roughly. So next is the, if you want to ask any question regarding this curve station, you can ask. So I am moving to the next computer-based CBA station is the biochemistry. This is a very crucial thing in the exam. It tests your ability to interpret laboratory data in the clinical context. So less cases than in other CBS, so around typically 8 or 9 cases. So in 90 seconds, or you can say 1.5 minute per case. Time is a very crucial issue in this station because questions are long and you have to read out very fast. So all cases are the real life cases, and usually it's arranged with increasing difficulty as per the judgment of the author, not necessarily the candidate. You may find some easy questions because maybe those concepts better. It tests your pattern recognition. That is whether a correct and quick diagnostic algorithm is running in candidate's brain. This is the skill that can only be gained by the daily practice. So you have to go for a practice of these biochemistry questions so that you can make some pattern recognition in your brain, and quick diagnostic algorithm should run in your brain. Then only you will do this type of questions. Otherwise, you will jumbled up the so many values given in the
weight, multiple layers. Then patients, the paramedics have been unable to obtain a temperature reading. So most of the things they have given you clue.
So as in every other CBA, candidate is allowed to skip a difficult slide and go back if time is left in the end. Sometimes only few values are displayed and sometimes a whole array of normal and abnormal results because it is in the real life. So you should not be surprised to see in some question there are few values, and some question a lot of values are given, normal as well as abnormal results. So you have to be prepared like that. Then clinical vignette would guide you what to look at. So some may be related to the difficult acid-base cases, sodium and water metabolism disorder like DI, SIADH, and cerebral salt wasting syndrome, or some underlying disease with a typical biochemical picture, like rhabdomyolysis, like refeeding syndrome. So they can ask these type of questions in the exam. One or two cases with hematological diagnosis. So this is very important to understand. You will get at least one or two questions related to the hematological diagnosis. Okay, like TTP, HUS, ITP, or DIC. Then one case testing the ability to a candidate to interpret lab data under unusual circumstances, like ABG in pregnancy. You have to check ABG during hypothermia. Suppose temperature is given in the test is taken from the patient who is hypothermic. So obviously the values will be changed. So you have to understand how the ABG values will be changed when a sample is taken from a hypothermic patient. Then both traditional and SI units are displayed and abnormal values are highlighted in the red. So basically you have to know medical disease with a pattern. So this is the way to prepare for the biochemistry cases. Then the third computer-based assessment station is the imaging. In imaging, there are 10 to 12 slides for the imaging, 15 minutes for CBA images. So you have time 60 to 90 seconds per slide. Usually 4 to 5 X-rays in CBA images. Questions commonly asked: the abnormality seen, what is the proposed intervention, what is the treatment. So in chest X-ray, you may find the X-ray related to the collapse, consolidation, infiltrates, pneumothorax, pleural effusion, pericardial effusion, or they can ask the position of the cannula, if ECMO cannula is there, any tubes, suppose Rice tube is there, or any foreign body, airway compression, cardiac sellout, mediastinal masses, and they can ask you to identify abnormality and what is the urgent intervention. So be prepared for the both questions. A systematic but quick and focused approach is advised. Answer the question. No cheap points awarded for describing a line in a normal position. So don't be extra smart to tell this thing or that thing. They will not give you marks because they have predefined points in the form of answers. And if you will tell only those answers, then only you will get the marks. Otherwise, not. So if you think that I am telling this thing, that thing, and I am getting marks, so this is not the picture. Then in lungs, alveolar versus interstitial collapse, recognize lobar collapse versus consolidation, and fluid versus post pneumonectomy, cyst cavity in pleura, pneumothorax, surgical emphysema, deep sulcus sign, pneumomediastinum, flail chest, fluid in the thorax, in diaphragmatic palsy, diaphragmatic rupture, pneumoperitoneum versus gastric bubble, bones, any fracture of the ribs and clavicle, missing ribs, abdominal X-ray, ileus, small bowel, large bowel, rupture viscous, toxic megacolon, nasojejunal tube position. So they can ask these types of things in the exam. Then in CT head, they can ask what the raised ICP signs, herniation, mass effect, hemorrhages like subdural, extradural, SAH, interparenchymal, large ventricle, hydrocephalus, atrophic brain, ischemia, early versus late sign, embolic versus arterial occlusion, MCA infarct. In CT chest, they can ask you about the aortic dissection, pulmonary embolus, in lung abscess, infiltrates, contusion, aspiration, edema, pleural space, pneumothorax, mediastinum, air, enlarged lymph nodes. In USG chest, fluid, signs of pneumothorax, consolidated lung, echo, tamponade, severe LV-RV dysfunction, severe hypovolemia. These things can be asked. In CT abdomen and USG abdomen, they can ask about the pneumoperitoneum, dead bowel, hemoperitoneum, contrast extravasation. This is very important. Damage to the parenchymatous organ like pancreatitis, hydronephrosis, fast scan, IVC assessment, and CBD and intrahepatic duct dilatation. So these are not the part of EDIC exam, like MRI, transcranial Doppler, small vessel angiogram, radionuclide studies, and advanced echo. These are usually not a part of EDIC exam. So don't go for these things. Otherwise, unnecessarily you will waste your time. Then I have already covered the stations, what they expect from you, and how should you prepare for these stations. Then we are moving towards the clinical case scenario, means CCS. I have already covered CBA, computer-based assessment. If you want to ask any question regarding the CBA part, you can ask.
Sir, waves and everything, then just ask the diagnosis or any other questions regarding the waveforms or
Usually two questions. What is the diagnosis and what will you troubleshoot? How you will troubleshoot? Suppose you are getting a trigger asynchrony, and so they can ask what type of asynchrony is this, or what type of abnormality in the ventilator waveform. Then how will you troubleshoot, or how will you correct it? So there are two questions. In ECG, they can ask what is the diagnosis. Suppose you are telling this is a inferior wall MI. Then the next question will be, what is the culprit artery? Okay.
okay, sir.
There is ROTEM and TEG is coming in TBS or no?
ROTEM and TEG, they can ask. This is not the exclusion, but usually they don't ask very tough question regarding ROTEM and TEG, but they can ask. So you have to prepare, especially in the curve section.
Okay, thanks.
Then moving towards the clinical case scenario. So there are now this EDIC 2 exam is a 2-day exam. On day 1, they can ask only 3 or 4 clinical case scenario, and CBA part will be taken on the day 2. Or for some students, it might possible that CBA part on day 1 and CCS part on day 2. And in CCS, earlier it was 3 cases, 3 long cases they discuss, but since few years they are asking 4 questions, 2 short cases and 2 long cases. And nowadays they are moving towards the 5 cases, 4 short cases and 1 long case. So basically they might change their pattern, and it doesn't make a difference. It will help you if they will ask more number of CCS cases. You are in a better position to give the answers, because if there are less number of CCS scenarios, then it might possible you have not know much about any one case. But if number of cases will increase, definitely you have better chances to pass through this exam, especially in clinical case scenario. So all CCS are the real patients. All examiners are the real intensivist. Introductory vignette extract from patient's note is given before 30 minutes to prepare 3 or 4 or 5 cases. The usually context is an emergency room in a large teaching hospital. Brief past medical history and presenting complaint or situation, and then some findings in the form of physical examination, imaging, lab values from my blood sample and ECG. So this is the starting of the case.